The following podcast is part of a certified educational activity titled How I Think, How I Treat, Remodeling the HCC Treatment Algorithm with New and Emerging Monotherapy, Combination, and Multimodal Approaches, featuring Richard Finn, MD, from the David Geffen School of Medicine at UCLA in Los Angeles, and Anthony El-Koheri, MD, from the USC Norris Comprehensive Cancer Center in Los Angeles. Access the entire activity and complete the post-test at peerview.com/AXW860. Downloadable slides are also available.
Welcome to this educational activity, How I Think, How I Treat, Remodeling the HCC Treatment Algorithm with New and Emerging Monotherapy, Combination, and Multimodality Approaches. I'm Dr. Richard Finn from the Geffen School of Medicine at UCLA, and I'm joined here today with my good friend and colleague, Dr. Anthony El-Koheri from the USC Norris Comprehensive Cancer Center.
Thank you, Richard. Thanks for having me.
In this activity, we'll be highlighting the latest developments in HCC, the recent data presented at the 2021 ASCO GI meeting, and discuss how we can enhance care for our patients with HCC. The paradigm for treating liver cancer has evolved rapidly over the past few years. Still, the backbone for how we approach patients and stage them is the Barcelona system. This system takes into account two important prognostic factors in liver cancer patients. That is their underlying liver disease and performance status, as well as anatomic characteristics of their cancer. This is a dynamic process for patients. On one end, we have patients who have advanced liver cancer, who have decompensated liver disease. Really, their survival will be dictated by their underlying liver disease and not their cancer. These patients often have Child-Pugh C liver disease. And outside of transplant, which may be applicable for patients who have small tumor burdens, these patients really receive best supportive care as they are too ill to receive treatment. On the other side are patients with early stage disease. These patients might have well-preserved liver function and go on to receive resection with curative intent. Or a subset of those patients with small tumors may do well with ablation, either microwave ablation or radiofrequency ablation, again with potentially curative intent. Or they may even be listed for transplant if their tumor is within transplant criteria and they are not candidates for a resection because of underlying liver disease. The attractive thing about transplant is it takes care of two problems. It takes care of their underlying liver disease as well as their malignancy. And transplant criteria are always changing. Therefore, it's very important, I think, for patients to be considered at a multidisciplinary center at their initial evaluation. And actually throughout their course, because patients can stage migrate. Some patients with intermediate stage disease, these are patients who have disease confined to their liver, who have well-preserved liver function, good performance status. The backbone for these patients has historically been chemoembolization. But some of these patients may have a good response to treatment and then become transplant candidates. But also we know that outside of transplant, patients who receive local regional treatment for intermediate disease eventually will stage migrate to advanced disease. Chemoembolization is not curative. It does improve survival, but eventually patients will become refractory to local regional treatment or develop characteristics of advanced disease, which is extrahepatic spread or invasion into the vasculature, such as portal vein invasion or a branch of the portal vein. And there we have data that has evolved over time that demonstrates that medical treatment or systemic treatment is really improving survival for these patients. And together with Dr. El-Koheri, we're going to review some of these evolving concepts in liver cancer management. So Anthony, at ASCO GI, we saw some updated data on atezolizumab and bevacizumab, but also in historical context can review the options we have for patients with frontline liver cancer.
Great, thanks, Richard. In short, I think at this point we can say that patients with advanced HCC, and the definition used for advanced HCC in these clinical trials is patients with portal vein invasion, or extrahepatic spread. It's and or. There's also a subset of patients, usually about 30% in these trials, who are intermediate stage BCLC-B patients who have progressed on liver-directed therapy or were really not ideal candidates for liver-directed therapy. So for these patients, the first option that's been around the longest is sorafenib, that had shown an improvement in survival over placebo. Then we had the REFLECT trial that showed that lenvatinib was non-inferior to sorafenib. And then the most recent data that Dr. Finn alluded to and led that study is the combination of atezolizumab and bevacizumab versus sorafenib, which had shown a 42% reduction in the risk of death with a hazard ratio of 0.58. At this meeting, ASCO GI 21, Dr. Finn updated the results and reported on the median overall survival with atezolizumab and bevacizumab, which was 19.2 months in comparison to 13.4 months with sorafenib. So the sorafenib arm here performed as well as it did in all the other modern trials that we had seen recently. And the median OS for atezobev is the longest reported in first line ever at this point. Similarly, we see an improvement in median PFS, which was a co-primary endpoint, 6.9 versus 4.3 months with sorafenib, a very promising response rate of 30% with the combination of atezobev. Of course, patient selection is important. All these patients had Child-Pugh disease, preserved performance status, no prior systemic therapy, and all had an endoscopy within 6 months of starting therapy in order to have their varices treated per institutional standard.
Yeah, so very exciting how we've seen some evolution in the management of patients with liver cancer. Still, we talk about clinical studies, and here we see some real-world data, Anthony.
Yes, so this is real-world data using lenvatinib, which again, as I showed earlier, was non-inferior to sorafenib in the REFLECT trial. This real-world data is based on a subset of investigators spanning academic centers, cancer centers, as well as private practices. This is based on a retrospective chart review. The follow-up for this group of patients, it's over 200 patients, is relatively short of around 9 months. But at least the activity that was reported in REFLECT seems to be still present here in this real-world data set. If anything, the response rates here appear to actually be a bit higher than reported in the clinical trial setting. Now, of course, this is a retrospective review, and these assessments are based on investigators' report of these responses, but nonetheless, we do see tumor reductions in the real world with lenvatinib, and we do see, these are landmark analyses of PFS and OS at 6 and 12 months, and again, the data here is very consistent with the phase 3 data, if not even a bit better than we had seen. So it's good to see this just to give more reassurance than what was seen in the phase 3 data is actually panning out in the real world.
Yeah, and obviously our clinical trials have restricted inclusion criteria. And here we actually see some data in Child-Pugh patients, which looks not too dissimilar from the activity in Child-Pugh. This poster did not have a lot of safety data, which is obviously something we would want to see for the Child-Pugh patients as well. But these real-world studies, I think, do have some usefulness as far as reassurance, and we've seen similar data with sorafenib or regorafenib in real-world settings as well. Now, the activity of immunotherapy historically, and you were involved with this, was demonstrated initially in second-line studies. Initially, your work with Checkmate 040 with single-agent nivolumab, and then we saw activity with single-agent pembrolizumab. However, the phase 3 studies for both those molecules did not reach their primary endpoints. And until the atezolizumab bevacizumab data, we were lacking really level 1 evidence for immunotherapy in advanced liver cancer. And now you can see from the NCCN guidelines with the results of IM-Brave 150 atezolizumab and bevacizumab is listed as a preferred regimen front line. But also, interestingly, they reserve nivolumab as an option in frontline single agent. And I think that's really based on the fact that we see really solid responses with single agent IO, even though in a phase 3 study, nivolumab did not improve survival statistically over sorafenib. But they have the caveat here, this would really be an option for patients who aren't candidates for a TKI for some toxicity, or they could not get bevacizumab and therefore the combination of atezo-bev. So when we talk about that monotherapy data, we see the results from Checkmate 459. That was the phase 3 study of single agent nivolumab versus sorafenib. Survival was 14.7 months with sorafenib, fairly long for a phase 3 study. But nivolumab gave a survival of 16.4 months. The hazard ratio was 0.85, and the p-value just missed that with 0.07, just missing significance. But we did see that single-agent nivolumab was well tolerated, and it reproduced a response rate of about 15% in this population. But still, that did not translate to a survival benefit. At ASCO GI, we saw some data of upfront pembrolizumab. Keynote 224 was a single-arm study of pembrolizumab in the second-line setting, as well as a cohort in frontline. And here you see a median survival of 17 months. Again, this is a single-arm study, but that 17 months is not too far different from that 16.4 months we saw with nivolumab. And again, I think this is a signal. Again, we want level 1 evidence of single-agent IO, but the data speaks very loudly to me that these drugs do help a population when given by themselves. The question is it any better than TKIs? And we haven't been able to prove that. But in combination, when we start getting response rates of 30%, as with atezo-bev, then we're able to improve survival. And there's other combinations that we'll discuss that are looking at this approach. When we're talking about those approaches, there are the IO combinations. Himalaya looking at the PD-L1 antibody durvalumab in combination with the CTLA-4 antibody tremelimumab. And Checkmate 9DW, which is looking at the combination of nivolumab with ipilimumab. And then there's combination studies of IO and kinase inhibitors. LEAP-002 looking at lenvatinib in combination with pembrolizumab, and the COSMIC 312 study, which is looking at the combination of cabozantinib and atezolizumab. Anthony, you're involved with cabozantinib. Could you review the study design here?
Sure. So this study is again based on the similar concept you alluded to of combining anti-PD-1 or PD-L1 agents with anti-VEGF agents. Now, cabozantinib is an oral TKI that is multi-targeted, but among its targets are VEGF receptor 2, MET, and AXL. It does have some immunomodulatory activity. We know that targeting VEGF can at least in the preclinical setting, create a potential synergy and enhance anti-tumor immunity. And I was referring to synergy with anti-PD-1 or PD-L1 therapy. We know that these TKIs can reduce some of the suppressor cell populations like myeloid-derived suppressor cells, and T-regulatory lymphocytes, and recruit cytotoxic CD8 T cells to the tumor microenvironment. So there is great biologic rationale for this. This study is taking previously untreated patients, Child-Pugh-A, advanced disease, so BCLC-B or C, and randomizing them to the combination of cabozantinib and atezolizumab versus cabozantinib alone. That's a small arm exploring the single agent activity in first line. And then the control arm is sorafenib. This study has completed accrual, and we look forward to the results. And it has co-primary endpoints of PFS and OS.
So the other TKI combination is this one of lenvatinib and pembrolizumab. This study we published in JCO last year, which really demonstrated significant activity. If we're looking at just conventional RECIST criteria, an overall response rate of 36% with a median duration of response over a year, disease control rate of 88%, and a very provocative PFS data with this of over 8 months, and median OS was 22 months. And most of the side effects from this combination were really driven by lenvatinib. Hypertension, proteinuria, anorexia, fatigue, and while we do see immune-mediated adverse events with pembrolizumab, they're really no different than single-agent pembrolizumab alone. And this regimen has moved into phase 3, and we're looking at lenvatinib and pembro versus lenvatinib and placebo in a very similar population you described, Anthony, in the COSMIC study. Frontline, Child-Pugh with good performance status. We have 2 primary endpoints of OS and PFS, and this study has completed accrual and is awaiting results. And now there's also data looking at other immunotherapies and TKIs. We have seen data evolving with regorafenib and pembro, and Anthony, I think you were involved with this combination as well.
Yes. So again, this is a similar concept to what you've shown, similar patient population. So this was initially a dose escalation study, started at pembro 120 milligrams with an option to escalate to 160 or go back down to 80. Based on the design of the study, it was determined that 120 milligrams was the MTD, with pembro 200 every 3 weeks. However, there was a high rate of dose reductions and interruptions from regorafenib because, as you alluded to, the toxicity was mostly driven by the TKI. So based on this, we are now exploring an 80 milligram cohort of regorafenib with pembrolizumab. In the 120 milligram cohort, which was over 30 patients, the response rate was 39% with a disease control rate of 94%. So again, difficult to do cross-trial comparisons here for phase 1 studies, but this is certainly in the same range as the pembro-lenva combination. The data for the 80 milligram cohort is a bit premature as far as efficacy. This was presented at ASCO GI with 21 patients. The majority of them were still on therapy, and the response rate is still evolving. But again, we see a disease control rate of 86% in the same range. There's another ongoing trial of tivozanib and durvalumab. Again, similar concept, and again, these will continue to read out over the several next months.
Yeah, so clearly there's some smoke, I would say, in these combinations of the multi-kinase inhibitors with IO. There's certainly a signal that we keep seeing, and you know, this idea of dose reducing the regorafenib is an interesting idea because maybe we don't need as much dosing on the TKI to get this synergy. You know, I think our hypothesis is that the TKIs are not only affecting the tumor, but perhaps the synergy is being driven by its effect on the tumor microenvironment. And maybe we do not need the full doses of the TKI, but you know, ongoing studies will try to figure that out. As you commented, these drugs were initially looked at in second line, and we do have ongoing approvals. Both single-agent nivolumab and single-agent pembrolizumab are approved with very similar response rates in the 15 to 20% range. And then you alluded to the data with the nivolumab and ipilimumab, which is showing response rates of 32% with long duration of response, and now is being looked at in the frontline setting in a phase 3 study. All of these were evaluated after prior TKIs. You know, in general, patients had received prior sorafenib. Now that we have atezo-bev in the front line, these probably would be reserved for patients who get TKIs in the front line. And also, we've seen a little more toxicity with the IO-IO combinations than with single-agent IO. So, you know, we've updated some of this data at ASCO GI. Keynote 240 was the pivotal study of pembrolizumab versus placebo. And at the time of the primary analysis, while we saw a strong trend in improvement in OS, you know, this data did not reach statistical significance because of the statistical analysis plan that was put in place. Here we see with longer follow-up, the trend was maintained. The placebo group had a survival of about 10 months and pembrolizumab just under 14 months, and this was a hazard ratio of 0.77. This is a nominal p-value since this was not the primary analysis, but you can see the 36-month survival rate with pembrolizumab was just under 18%. So there certainly is a group of patients who get a very strong benefit from this drug. Interestingly, even in the placebo group, about 12% of patients had long-term survival, which I think really reflects the impact of new treatments that have been available for our patients in second line, which were not initially available when we designed Keynote 240. Similarly, there was updated data from Checkmate 040, which shows that this signal that was seen with the Ipi/Nivo dosing that was used now with accelerated approval is showing a tail to the curve. And you can see here that out over 3 years, there are patients who have long-term survival with this combination. And this, I don't think, is too dissimilar to what we've seen with IO in other malignancies. Keynote 240 also presented at ASCO GI this landmark analysis looking at survival by response. And again, Anthony, you had shown some data initially with Checkmate 040 with single agent nivolumab that the responders really have a different survival than the general population. And again, this is typically retrospective and there are caveats to this analysis. But here we looked at patients, their survival if they were a responder at week 18 versus those patients who are not responders. So that includes stable disease and progression. And you can see here the median survival for that group is 10.8 months. And for those patients who have a response, we still have not reached the median survival. This was a hazard ratio of 0.37. What we don't have is a way to predict who these patients will be. How do we know who will respond up front? And obviously, if we had some way of doing that, we could enrich for that population. So there are several agents currently approved in second line based on phase 3 data: regorafenib, cabozantinib, and ramucirumab. The data for these agents, certainly the two TKIs, is very similar. Here, looking at the survival data. Keep in mind, the regorafenib population had to have tolerability of sorafenib for some period of time with documented radiographic progression, where cabozantinib did allow patients who were intolerant to sorafenib or had radiographic progression. And they also included a population that was third line. But needless to say, the survival data is fairly similar and the hazard ratios are not too dissimilar either. And the TKA profiles for these two drugs are not too different. The typical type of toxicities we see: hypertension, hand-foot skin reaction, GI toxicity. Ramucirumab is a little different because it's a monoclonal antibody to the VEGF receptor. We know that in the pivotal study, they looked at patients who were intolerant or progressed on sorafenib, but restricted their accrual to patients who had an elevated AFP. And this came out of some retrospective analysis from prior studies. And while the absolute improvement in OS of 5 to 8.1 months comes from a pooled analysis of various studies, the hazard ratio is very similar, I would argue, to the TKIs. And as a monoclonal, it does not have some of the typical TKI toxicities we see, such as hand-foot skin reaction, and the GI toxicity is a little more favorable. So, how we think about treating patients is evolving. Sequencing is becoming important. That is to say, we have various options now in front line and numerous options in second line and beyond. This idea beyond second line in liver cancer is a totally new concept, in that we now have several drugs and patients tend to be living longer, and as they have better preserved liver function, they'll be candidates for sequencing these agents in the future. What we don't have is data on the optimal sequence, and we'll be looking at probably real-world data on that sometime in the future. So one area that's not covered perfectly by the clinical trials is this Child-Pugh-B population, right? And these are patients who suffer from more significant liver disease. Anthony, can you go over some of the evolving clinical data in this population?
Certainly. First, let's cover the Checkmate 040 cohort of Child-Pugh-B patients. These are patients with Child-Pugh-B 7 or 8. Of course, they could not have needed a paracentesis in the past 6 months prior to enrollment or have had active hepatic encephalopathy. So they're patients with Child-Pugh-B but who are not actively decompensated. And here you see in this cohort of 50 patients that the safety was actually quite similar to the Child-Pugh-A cohort with slightly more frequent hepatic events. It's difficult to say whether these were treatment-related or just underlying liver disease. But the response rate, again, was in the range similar to the Child-Pugh-A cohort. So the response rate was 12%, disease control rate 55%. The responses were durable with a median duration of 9.9 months. And the median OS for this Child-Pugh-B cohort was 7.6 months, which compares favorably to historical data reported from different data sets, including the Gideon real-world registry with sorafenib. So intriguing data set. It speaks to the feasibility of using this agent in select Child-Pugh-B patients going forward.
And, there was this data set also with the TKIs.
Yes, so both of these data sets from Celestial and Reflect look at patients who started at Child-Pugh-A and transitioned to become Child-Pugh-B patients at week 8, which was the first assessment of the Child-Pugh score on these trials. And in a nutshell, you see that in this subset of patients that went from Child-Pugh-A to B, they still had an improvement in median OS and median PFS compared to the control arm in both trials. So the activity at least was maintained, and the safety profile for these Child-Pugh-B patients, again, was consistent with the overall safety in those two phase 3 studies. There's an ongoing phase 1-2 study of cabozantinib specifically in Child-Pugh-B patients 7 and 8. Again, small study to establish the safety prospectively.
So, these are some data sets that are building some confidence for us that maybe some Child-Pugh-B patients may still get a benefit from treatment. And I think it becomes tricky because it's patient selection, because we do not want to hurt patients, but there are some patients who technically are Child-Pugh-B, but do come to clinic, have preserved performance status, and may be reasonable to offer treatments. We'll transition now to intermediate stage and earlier stages to wrap up the program. And we've discussed that stage B patients are the ones who typically are managed with chemoembolization. There's been a lot of interest in trying to move systemic treatment into the earlier stage population. And up to this point, those studies, phase 3 studies, have concentrated on the TKIs, mostly sorafenib. And unfortunately, they have not really reached high quality endpoints of improving PFS or survival by moving these agents to earlier settings. At ASCO GI this year, we've seen an update to the TACTICS data set, which did look at sorafenib in combination with TACE using some novel endpoints. And while there is a trend towards an improvement in PFS, OS was not improved moving sorafenib to the earlier setting. And in the context of these studies that were mostly negative with sorafenib, I think at this point, most of us would not use TKIs automatically in combination with local regional treatment. But there is a scientific reason to look at immunotherapy now with liver-directed therapy. We know that from these studies that have been done at the NCI and other places that when we damage the liver with local regional therapy, or damage the tumor, I should say, there is antigen release, which could then stimulate an immune response that is augmented by checkpoint blockade. And this study did demonstrate that, as well as increasing responses in sites that were not treated. This idea of an abscopal effect, that you treat the tumor in the liver and then use immunotherapy and you get a systemic response. And there's a number of ongoing therapies now looking at local regional treatment with the immunotherapy single agents and combinations. and those are listed here. All of these studies are ongoing accrual. A new approach that's being looked at is tumor-treating fields. This approach has been looked at in glioblastomas and actually is approved. And it looks at using alternating electrical currents to treat these tumors. And it's now being looked at in liver cancer for patients who have liver-confined disease, a small study, and an interesting approach for local treatment. And certainly it appears to be well tolerated in the brain tumor population, and we'll have to see if this stands up for liver cancer as well. So how about moving drugs to the post-resection setting, Anthony?
So again, this is an area of unmet need, patients with high recurrence rates post-resection. We have no current standard adjuvant therapy. Here is a list of the factors associated with a higher risk of outcome, so multinodular disease, larger tumors, having positive margins, as well as blood loss. All of these have been associated with higher risk of recurrence. The largest adjuvant trial that was done well was the STORM study, looking at adjuvant sorafenib post-resection or ablation, which did not show an improvement in recurrence-free survival and overall survival. So it was a negative trial.
And now there are studies looking at all these immunotherapy agents that we talked about throughout the program being looked at in the post-resection setting. And perhaps given their increased activity, maybe these studies will be positive. And also moving drugs to the neoadjuvant space. This small study looked at neoadjuvant cabozantinib and nivolumab, a very interesting approach because also we can get biologic data. And, in this setting, in patients who had larger tumors, there was actually some patients who had complete pathologic response. So a new concept in liver cancer, not ready for prime time yet, but an exciting area that's going to be pursued, I think, even more so in the future. And so, we've talked over a few things. Anthony, do you want to wrap up your thoughts on these three concepts?
Sure. So I would say in addition, to just summarize, in addition to atezo-bev becoming the new standard of care in first line, what we're learning now is that there is a subset of Child-Pugh-B patients in whom we could use nivolumab or the TKIs like cabozantinib or lenvatinib safely. So there's more emerging data, and we look forward to more data in this space. In the intermediate stage setting, there are more combinatorial type approaches looking at liver-directed therapy plus immunotherapy, either single agent or in combinations. And then lastly, we have multiple emerging strategies and modalities like the TTF fields that you mentioned, as well as looking at these systemic therapy agents, including immunotherapy in a neoadjuvant or adjuvant setting. So certainly a lot of activity and a lot of promise going forward.
Yeah, and we've certainly come a far way with phase 3 data, but we still have a way to go. And I think we highlighted some of the areas that are being actively pursued, and we'll wait for that data. So, Anthony, as always, a great discussion. Thank you very much.
Thank you, Richard. This was great.
And thank you all to participating in today's activity. I hope you enjoyed the program and will incorporate some of these concepts into your daily practice. Thank you very much.
Medical Learning Institute Incorporated is accredited by the Accreditation Council for Continuing Medical Education, ACCME, to provide continuing medical education for physicians. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/AXW860. This educational activity is supported by medical education grants from ISI Incorporated, Exelixis Incorporated, Merck & Company Incorporated, and Novocure.